Today I'll be discussing EUS-guided RFA for the management of pancreatic neuroendocrine tumors. Pancreatic neuroendocrine tumors are neoplasms that arise from the endocrine tissue of the pancreas. Up to 75% of the pancreatic neuroendocrine tumors are non-functioning. The ones that are functioning are named after the hormones that they secrete. These are rare tumors and account for 1 to 2% of all pancreatic tumors. Most often they occur in the 4th to 6th decade of life, and are usually sporadic but can be associated with certain syndromes. So the mainstay of treatment for pancreatic neuroendocrine tumors is surgery. So then why do we need a minimally invasive alternative? And this is highlighted by the systematic review, which assessed for the complications related to surgery for pancreatic neuroendocrine tumors. And what this study suggested was that no matter what type of surgery you do, whether it's enucleation, distal pancreatectomy, pancreatidodenectomy, or central pancreatectomy, the risk of complications is high. And these include pancreatic fistulas, delayed gastric emptying, and post-operative hemorrhage. Also, the in-hospital mortality is quite significant for each one of these surgeries. Patients that have pancreatic surgery also have a cumulative incidence of developing endocrine insufficiency in up to 20% of the cases. And they can also develop exocrine insufficiency in 36% of the cases. Patients who have surgery for pancreatic neuroendocrine tumors are usually younger and also have better survival, and therefore the overall cumulative incidence for both endocrine and exocrine will be much higher than this. Since the late 1990s, EUS-guided intratumoral therapies have been attempted to treat solid pancreatic tumors. And people have tried photodynamic therapy, cryotherapy, implantation of brachytherapy seeds, direct injections of chemotherapeutic agents, and alcohol ablation. And more recently, radiofrequency ablation has also been done. So RFA, how does it work? Essentially, RFA causes direct tissue injury through targeted hypothermia. A high-frequency alternating current generates temperatures between 60 and 100 degrees centigrade to induce coagulative necrosis via a bipolar electrode array. Outside the core ablation zone, there is a transitional zone of sublethal hypothermia. Therefore, the surrounding tissue remains unaffected. This is what the EUS RFA kit looks like, with a RFA generator, a water pump, an electrode, some grounding pads, and tubing. The electrode tip has an active tip, which is usually 10 millimeter in size, an insulating area, and a jacket sheet. Whereas the water pump pumps cold water throughout the needle to avoid excessive damage due to heat. The power settings determine the size of the ablation zone, but as a general rule, the smaller the power, the longer time it is used and the bigger volume of ablation. The bigger the power, the shorter time it is used and the smaller volume of ablation. I would like to share a case that we did recently for an EUS-guided RFA for a functioning pancreatic neuroendocrine tumor. So our case is of a 48-year-old female who presented with a 3-month history of hypoglycemia. Her blood tests suggested biochemical evidence of an insulinoma. Her blood insulin levels were high with low blood glucose levels. An MRI scan of the abdomen revealed a normal pancreas, and because of that, the patient was referred to our department for a diagnostic EUS. At EUS, a 13 millimeter hypercoagulation was identified at the junction of the body and tail of the pancreas. Biopsies confirmed it to be a neuroendocrine tumor with a Chi-67 of 1%. The patient was offered surgery, however, she opted for radiofrequency ablation. Prior to the procedure, the patient was having dangerously low blood glucose levels, but following the procedure, her blood glucose stabilized. This was observed for the next 24 hours and the patient did not have any episodes of hypoglycemia. The patient remained stable and was discharged. She was then seen after a week's time and her blood glucose was noticed to remain stable over the past week. So what is the evidence of EUS-guided RFA? This has been looked into this retrospective study, retrieving all consecutive patients who underwent pancreatic EUS RFA during 2019 and 2020 in France. 100 patients affected by 104 neoplasms were included, 64 of which were neuroendocrine neoplasms, 23 had metastases, and 10 had IPMNs with mural nodules. And what was noticed was that the procedure-related mortality was 0%. Adverse events happened in up to 22% of the cases, and one of the main causes of adverse events was noted to be the proximity to the main pancreatic duct. Complete tumor response was noted in 60.2%. At independent factors related to complete tumor ablations on multivariate analysis included the presence of neuroendocrine tumors and neoplasms that were less than 20 millimeters in diameter. In this meta-analysis, EUS-guided RFA and ethanol ablation for pancreatic neuroendocrine tumors was assessed. A total of 204 lesions from 20 studies were included. 113 patients had EUS-guided RFA, whereas 91 patients underwent EUS-guided alcohol ablation. Functioning lesions were reported in 41.6% of the EUS-guided RFA group. The pool rate of clinical success after EUS-guided RFA was 85.2%, whereas the pool rate of adverse events was 14.1%. The total adverse events were 12 in the EUS RFA group, 95% of which had either mild acute pancreatitis or mild abdominal pain. One case developed pancreatic fistula. These are the forest plots related to the study. More recently, the RAPNET study has concluded, which was a prospective study to assess the use of radiofrequency ablation for the treatment of pancreatic neuroendocrine tumors. The results of this study are currently not available. Case series have been published reporting EUS-guided RFA for insulinomas and show good efficacy. The adverse events have been also low in most of the studies. In this particular study that was published in 2023, EUS-guided RFA was compared with surgery for insulinomas. Patients were identified and outcomes compared using a propensity matching analysis. The primary outcome was safety, whereas the secondary outcome was clinical efficacy, hospital stay, and recurrence rate after EUS-guided RFA. Using propensity score matching, 89 patients were allocated in each group and were evenly distributed. And it was noticed that the rate of adverse events was 61.8% in the surgical group as compared to 18% in the EUS-guided RFA group. Severe adverse events occurred in 15.7% of the cases that had surgery and was 0 in the cases that had EUS-guided RFA. Hospital stay was also considerably higher at 11.1 days with the surgical treatment as compared to 3 days with the EUS-guided RFA. Although the mean duration of follow-up was much higher in the surgical group at 37 months as compared to the EUS group of 23 months. 15 lesions reoccurred after EUS-guided RFA and underwent a successful repeat EUS-guided RFA or surgical resection. The adverse events that have been reported after EUS-guided RFA for insulinoma include mild abdominal pain, mild pancreatitis, pyrexia, and an episode of life-threatening bleeding in one patient. So in a nutshell, an ideal candidate for EUS-guided RFA is a patient that has biopsy-proven low-grade neuroendocrine tumor with a Chi-67 of less than 1%, tumor size of less than 20 millimeter. The lesion has to be away from the pancreatic duct and vessel, and the patient should not be a surgical candidate due to comorbidities, technical issues, or patient's wishes. EUS-guided RFA is a promising new modality for tumor ablation. It appears to be safe and effective for this purpose. It may be safely repeated if required, and a few tips for optimizing ablation include using a 19-gauge 10mm electrode, multiple points or lines of ablations, and using contrast-enhanced EUS-guided RFA to assess for completion of the RFA procedure. Thank you.